welcome everybody. This is our monthly SWAC meeting. It's delayed a little bit because TCT kind of threw a wrench in our plans, but we're really honored today to have Dr. Mark Bieniarz, Dr. Tom Waggoner, who are moderators, and then Philippe Généreux and Sorajja are going to be talking about some highlights from TCT. We're going to start with Philippe. Philippe is the luminary that has been working his last decade to push the TAVR space forward, focusing on earlier intervention for severe aortic stenosis. And I think he just has a really innovative way of looking at this. And he really had kind of the highlight of all the late-breaking sessions at TCT, which was early TAVR. So he's going to talk to us a little bit about that. And it's an opportunity for us to explore it a little bit, dig into it. So Philippe, thank you, man. Really appreciate you being here.
Well, it's a pleasure to share those data with you guys. And I have to say that, yeah, it was a pretty emotional day because at TCT, I was presenting on behalf of the early TAVR investigator, 8 years of hard work. And people say it's groundbreaking, but for me, it's really presenting common sense. And when I look at the conclusion, we should just not wait. It's very common sense, but I guess it took 8 years and 900 patient randomized trial to show the common sense to people. So, but I'm very happy to share those data with you. And I guess we're gonna have the chance to go in detail and explain the pro and cons of both strategy. And I'm gonna present you also two concepts that actually I will present probably for the first time on here on SWAC, and Murmur. Which is a meta-analysis of the 4 trials actually that we did, and it was going to be published in JACC soon.
Philippe, we really appreciate you guys joining. I was having trouble with the audio. On behalf of SWAC and Murmur MD, myself, Joe, Mark Bieniarz, and the rest of the crew, Aiden, we really appreciate you guys joining. I'm here actually with a guest from out of town. This is Dr. Carrie Felt from Sweden, who came over just to join us for this special SWAC edition. So Carrie is on.
Nice to meet you.
He's one of the stellar imagers in the space, and we really appreciate you guys joining. So, Philippe, don't get too emotional with this, but we really appreciate you joining, man.
It's okay. I'm going to stop crying. So, yeah, I'm going to talk about TAVR for asymptomatic severe AS, so the result of the early TAVR trial, and I'm going to serve those results so we can discuss those results. So, we all know as a background, the guideline says to wait, if you have severe AS with no symptom, normal AF, the guidance said to wait 6 to 12 months and wait for symptom before treating. There's 2 small trial, Recovery and Avatar, that 150 patient roughly show that potentially surgical AVR in younger patient was beneficial. But there is no randomized trial today that was exploring the role of early TAVR for severe AS no symptom, especially in 80 years old patient. So that was the goal of the trial. And the goal was really to determine the safety, the effectiveness of early intervention with TAVR compared to watchful waiting for patients with severe AS no symptoms. And early TAVR was a robust, well-designed, randomized trial, 75 centers. All the patients were asymptomatic. The vast majority confirmed with a negative treadmill stress test, which I think really increased the robustness of the symptoms. They were clearly, truly asymptomatic. And randomized 1-for-1 to TF TAVR with SAPIEN 3 or Ultra to clinical surveillance. And the primary endpoint was tested for superiority with composite of all-cause death, stroke, or unplanned cardiovascular hospitalization at a minimum of 2 years. And those are the sites: 75 center, 72 in US, 3 in Canada. And some of you were, Joe, you were part of this. So the key inclusion criteria: above 65 or equal to 65 years old, severe AS by standard criteria, EF normal more than 50. And again, I said asymptomatic status was confirmed with a negative stress test. We accept up to 10% of the patient. If they were not able to perform the stress test, orthopedic issue, whatever, they could be in the trial. And the STS has to be 10 or less. Key exclusion criteria, mainly if you had a class 1 indication for AVR, or if you have an anatomy that was not suitable for TF TAVR with a balloon expandable valve. We accepted bicuspid if they were suitable and optimal for TAVR. Like I said, primary endpoint, all-cause mortality, stroke, unplanned CV hospitalization. All the patient at a minimum of 2 years follow-up, and it was tested for superiority in the intent to treat population. And the definition of unplanned CV hospitalization, we can discuss that. was defined as any cardiovascular hospitalization through the emergency room or admission from clinic for therapy intensification or lasting more or equal than 24 hours. And every TAVR or crossover within the first 6 months were considered unplanned. And the reason why we said that, it's because the guidelines said that the next planned visit is at 6 months. And we can discuss the relevance of this definition. Secondary endpoint were tested in a hierarchical fashion. So first was favorable health status outcome, alive at 2 years, key CCQ score more than 75, and no drop more than 10 points from baseline. Then we have a measure of cardiac damage at 2 years, LV or LA health, and you can see the definition about strain in LV, mass index, and LE volume. Then change in LVEF from baseline at 2 years, new onset AFib, and death or disabling stroke. So they were just pre-specified secondary endpoint. So we screened 1,578 patients between March of 2017 and December 2021. It was right in the middle of COVID. And from that, we excluded 43%. And the vast majority of patients, almost 40%, the exclusion were because they already had symptoms. They had a positive stress test. They have a low AF. So that's important to say. So this is high volume center that say, hey, yeah, I want to randomize an early TAVR, but they already had a class 1 indication in 40% of the time. So those patients were excluded. And then 30% were because they have an exclusion for TAVR TF with balloon expandable, LVOT calcium, bicuspid, low corners. Patient when randomized, 901 patient randomized 1-to-1, TF TAVR or surveillance, 455 versus 446. Every patient had a minimum of follow-up of 2 years, and the median follow-up was 3.8 years. So we had a kind of decent follow-up for those patients. And what was remarkable is 97% plus of those patients had data available for the primary endpoint analysis. Nobody dropped. Few people would draw or were lost follow-up.
Philippe, let me interrupt you if you don't mind. I'm just curious at your take when you randomize a patient in a clinical trial to a control, which is just medications versus intervention. So interventional trials I find are kind of challenging at times to enroll patients when they're being enrolled versus a device or a control. What's your take on this trial when the valve is severe with or without symptoms? Was it easier to get patients to say, yes, I want it fixed, or hey, I still want to wait with medical therapy?
I had to tell you this study had to have your narrative fixed because it was hard. Yeah. Most of the patient, for example, if I take the PROGRESS trial or I'm sure the EXPAND 2 trial for Paul, the moderate AS with symptom, they want to be treated. They don't feel good. This trial, they feel great. They have a stress test, they feel great, and have normal AF. So some of them will say, well, I'm good, so I'm okay to wait. And some of them were, I want to be treated, I don't want to sit on this. So it was really 50-50. Yeah. And I always said that the vast majority understood the equipoise, and we can do both. The guidelines say waiting. So the vast majority were fine, but we had to spend a lot of time with the patient because it's stress test and wait and why you want to wait. And it was a good 30 minutes with the patient. It was not like a slam dunk stand A versus B or I have a less invasive procedure for you. So it was this is a hard trial to enroll. Okay, and that's why it took 5 years 4 years and a half to enroll, 2 years follow up in COVID. So that was a hard, was heavy lifting here. Yeah.
Paul, how about for you? What's your take when you think about this from the mitral trials? Is it kind of in the same vein, I would imagine?
Yeah, I mean, Philippe said it really well. It takes a special effort to be able to tell a patient, we know you have severe disease, but you should wait. And so. So one of the call outs that people ask is that, how many of these patients actually did have symptoms? And Philippe actually showed that actually a lot of them were proposed with symptoms, it turns out. And so having that nuanced discussion is challenging, and Philippe and the study organizers really did an amazing job in calling out the truly asymptomatic patients. So,
and I think it's really important, as Philippe said, that the narrative is given to the patients. And we describe this, and we're so used to in cardiology defining symptoms. But I like to tell people you have a life-threatening illness. This is a terminal illness that you have. And so that really cages the discussion, almost like a cancer discussion, because a lot of cancer is treated with no symptoms.
Yeah.
People know that they have a life-threatening illness, and so if this is seen as a terminal illness, then this becomes much more palatable to people.
Yeah. But when they have minimal to no symptoms, though, for me, it's always getting that narrative going can be challenging to get people to buy in sometimes. So I was just interested to see how other centers approach it.
I think your question is good because the challenge with this trial was you don't want to scare them too much. A lot of time they send by a referring doctor. You have a ticking time bomb. You're gonna die. You have 50% chance of to be dead at 2 years. The Brown wall curve that were fabricated. And then after that, you have if you say no, you can wait. So you falsely reassure people. So it was a very fine line, and the narrative was really to say you have a disease. The guidelines said to wait, but there's evidence that maybe we should help you to prevent rarely mortality, but mainly prevent damage and have a less dramatic presentation.
Yeah.
You had to be balanced because obviously if in your head you don't have equipoise or mortality, of course you don't do the trial. If it's so obvious that people will die if you wait 6 months, why you do this? So the equipoise was key, but we all have our bias and preconception. So add an extra effort to be balanced when you present this. Yeah.
Fantastic. All right.
So I'm going to go quickly. The baseline characteristics are very important because this is 76 years old. Okay. So this is a TAVR population. We have the max age was 96. Okay. So we had 10% of the patient were above 85 and the top age was 96 years old. So it's really a TAVR population, and we have already surgical trial, 2 small abattoir recovery that are 65 average mean age. This is a TAVR population, 76, 30% female. Heart team, 84% were low risk, okay, by the heart team. 90% plus at a treadmill that were negative based on age and gender for the percent of the Mets. 93 KCCQ score, which is better than all of us. They were like normally you have 67% normal KCCQ score, and 9% roughly were bicuspid. This is where very similar echo finding in both group, but look at the EF, 67%, peak velocity 4.3 was not. We have some 5, we have some 5.5, but mainly was standard high gradient concordant AS with AVA less than 1 and peak velocity more than 4 or mean gray more than 40. And this is a primary endpoint. You can see the primary endpoint of death, stroke, or unplanned cardiovascular hospitalization was reduced by 50% with the early TAVR arm compared to clinical surveillance, and the NNT was 6 patient treat to save, avoid 1 event at 2 years.
That is so powerful, man. I mean, that's amazing. NNT of 6 patients at 2 years to reduce mortality that dramatically. I mean, for an interventional device trial, that's amazing. That's got to be near the top.
So it's interesting. You get the immediate separation, and so is that when patients cross over then and are treated?
Right.
Like, if you do a treatment analysis.
Yeah, we're going to talk about that.
Okay.
So when we design, if I have to redesign the trial, I will choose a different endpoint. But 8 years later, it's too late. But we took the 6-month bump is really because we consider every crossover within 6 months as an event. Why? Because the guidelines say to wait 6 to 12 months. So if you go on a cruise for 6 months because you say you're okay and you need a TAVR on the cruise, that's a problem. So we really define any event within the first 6 months or any TAVR as a crossover within the first 6 months as an event. And this is Kaplan-Meier estimate, which is the first time to first event. So when we check for this, you're good for the primary endpoint. But we run an alternative endpoint. You're going to see that increase the
So Philippe, one more question from here from Tucson. What was the NT-proBNP level at baseline? Did these asymptomatic patients have any NT-proBNP elevations?
Yes. So it was, I think I have it in the back, but it was around 250. Okay.
Right.
But it's funny. Some people were high, and we didn't have this result. We could not have this result. And that would be obviously Brian Lindman will present this at ACC, most likely the biomarker analysis. You see very interesting stuff. You see when people cross over, they skyrocket their BNP within the first 6 months. And so people were anxious in the first 6 months. No, this is a real crash and burn scenario within the first 6 months. And the granularity of the conversion, the description of symptoms is so key. And in New England, you cannot put too much, but multiple analysis will show that 40% of those patients within the first 6 months were crash and burn scenario. So, but to your point, some were normal, some were not.
Right. Right.
So this is the primary endpoint, just presented as a number of event. And you see 122 patient at an event in TAVR group and versus 202, highly significant. No difference in mortality, even if I like to say a trend, but I can't say that. And the important thing here is you have a numerically, and this is a very interesting finding, numerically lower rate of stroke with early TAVR compared to clinical surveillance. That was for me the most important finding and surprising finding. We designed this the opposite. We said we're going to have a price to pay if you do early intervention, and find out that the stroke rate in early TAVR was 0.9, and when clinical surveillance, when they crossover, was 1.8. And there was stroke that happened while waiting, which is probably because you accumulate cardiac damage, you have AFib you don't detect, and your LA gets sicker. And when you do the TAVR in 1 or 2 years after, you're sicker, you're more inflamed, you're probably more thrombotic, you have more stroke. So that's for me, we could not put too much emphasis on that because it was not pre-specified. But for me, it's when you see 50% reduction in stroke, this is something Sentinel would like to see. And you know, this is something that we show. There's no difference in mortality, and we can discuss that, why it is. Numerically higher rate of stroke, almost significant. And you see, the important thing is the curve diverge with time. And it's very fascinating, and I think much more need to be done in this field, but that's very interesting. Obviously, all driven by hospitalization for cardiovascular hospitalization, and then also heart failure. We're going to see more. So there is no difference in the subgroup analysis. They were all benefit for early TAVR in all the different subgroup. We ran a series of other alternative primary endpoint, or I would say additional composite endpoint. This one is the most common one, accepted one: death, stroke, or hospitalization for heart failure, which when you look, actually, the hospitalization for heart failure was really, if you need diuresis, you need inotrope, you need balloon pump, you're almost on the vent, or you need dialysis. This is a real hard endpoint for heart failure. They're not like I'm shorter breath class 2. So, and we remove all the noise of, when you cross over, you're in an event. Just heart failure, death, stroke, and this is where you still have 40% reduction. I think for me is the convincing slide. Is if you wait, you're going to have more heart failure. So in terms of pre-specified secondary endpoint, early TAVR was superior in terms of quality of life and mortality together, so favorable health status outcome. And we also were favorable in terms of integrated LV and LA health in terms of cardiac damage. Okay, so for me, it's important. And then we didn't have any difference on the other secondary endpoint. Why we didn't have a difference on LVEF? Because probably LVEF is hard. It's a very macroscopic way, and it's not enough granular for it.
Well, normal. You started with normal.
Exactly.
So you can't make normal more normal.
Yeah, exactly. So the change. So exactly. So that's why for me the integrated LV LAL, the strain, the LV mass, diastatic dysfunction is much more important. But yeah. This is I will say what's important is the conversion to AVR. Among the patients that were in clinical surveillance, okay, the median time of conversion was 11 months. 26% converted 6 months, half at 1 year, 70% at 7, and 70% plus at 2 years. Okay, right now, after 3.8 years, after 4 years, only 9 patients are waiting to cross over. Okay, wow. So the point is people cross over. Okay. And this is for me the natural evolution of the disease, and this is the next slide, or the most important one. What were the symptoms at time of conversion? A lot of people had multiple symptoms, but 83% have shortness of breath, and 30% were in class 3 or 4. Okay, so 30% was in class advanced heart failure. This is my concoction, actually. This is, I wanted to classify patient by cluster or phenotype of symptom. How many patients convert when they were had no symptoms? How many patients convert when they were what I call progressive valve syndrome, or class 2 soft symptoms? How many were in what I call acute valve syndrome, crash and burn scenario, acute decompensation, class 3 or 4 heart failure, syncope, being resuscitated for VTAC, drop of EF more than 50%, pulmonary edema, the real deal. Well, this is what we see. Through time, 40% of patients converted with advanced symptoms, real deal. 60% converted with class 2, I'm short of breath fatigue, and only 1.8 or 2% approximately convert with no symptoms. Among the 11 patients that convert with no symptom, they all have class 2A or 2B indication, peak velocity more than 5, increase in NT-proBNP, the drop of EF more than 50. They all have indication. No one converted with no class 2A or 2B indication.
Philippe, could you correlate those patients with advanced symptoms to the patients that had more advanced cardiac damage?
So that's ACC.
All right.
So
Mark, it's a really, really great question and concept you're alluding to, because I think that's where the money's at. That's where it makes sense. Yep. When you begin to see myocardial damage, whether it's a BNP, as what Carrie was alluding to earlier, whether it's nuanced AFib, whether it's LVH to a certain degree, evidence of diastolic heart failure echo, those are the changes in patients that are not even really symptomatic that really should push you more to valve implantation. We don't want to get to the point where we're chasing our tails, implanting valves when they're in critical end-stage valve disease and acute valve syndromes. We want to be treating patients before they get to that point. I think this study really begins to reinforce that.
Yeah, and I think that the key, this is a different slide that Alan Schwartz pushed us to do, but just show differently. At every time point, 40% of the patient convert with advanced symptom, and especially also in the first 6 months. The first 6 months is I would say, the Achilles heel of early TAVR. People say, oh, it's conversion. It's like FAME2 trial. People convert, they were nervous. Well, 40% of them were in pulmonary edema. There's a couple of patients that crash and burn, CPR, rupture palpable muscle, EF 20%. They need urgent AVR and VR. So there's 40% of this patient is what you want to avoid. For me, you can say, I can roll the dice and we can wait, but you may have 40% chance to come dramatically with symptoms that you're not going to like. And another slide we could not show because the New England was limited, but is in the appendix, is you see the dip in KCCQ score. If you convert within 0 to 3 months, the dip is almost 40-point dip in QCCQ score. If you go to 3 to 6, it's 25. And etc. So the earlier the conversion, the deeper you have the dip in the KCCQ score. So I think this is where we're going to focus for ACC, is what the description and the clinical surveillance crossover, how they convert the damage, the BNP, the biomarker, etc. So that's pushed us to do another additional endpoint, composite endpoint, to say, okay, if we will have take death, stroke, and every crossover or conversion to AVR due to advanced symptoms, okay? Instead of everybody at 6 months, it's positive. Just through time, every time you show up with advanced symptom, it's an endpoint. We will have also the same 50% reduction in primary endpoint. And I think the death, stroke, heart failure hospitalization, and this additional endpoint really increase the robustness of the early TAVR, and it's kind of additional way to see the data that is probably more standard and more reassuring from a clinical point of view. And I think it's a great complement to the study. One point about how ready and prompt we were to treat. So the readiness and the prompt in the treatment in early TAVR make it a very robust study. When you look in the early TAVR, when you were randomized in early TAVR, everybody has a CAT scan. S326, right side, you knew it. Also, you all screen for the cancer. A lot of patients we screen, oh, you have a kidney cancer, treat the kidney cancer, and then boom, you randomize again. We really optimize everything. So you're ready. And then the median time to treatment in early TAVR was 14 days, okay, in early TAVR group. And when you were following a clinical surveillance group and you start to develop symptom, your median time to AVR indication to treatment was 32 days. And 90% of the patient were treated within 3 months, which this is Target AS initiative. Actually, we proved a Target AS initiative that it's working to mitigate the mortality of waiting. So people say, well, you don't have the difference in mortality in early TAVR. Of course we don't, because we treat people. We don't wait, because we decide not to let them die. Because the mortality creep with symptoms on the waiting list when you wait 6 to 12 months with symptoms. We treat them in 30 days. So I think we were too good in the clinical surveillance. We really had the best clinical surveillance we had, which probably would never be replicated in the real world. And we address under treatment and we mitigate mortality. And that's the reason why we don't have benefit of mortality, which is a good thing. We didn't let people die.
Philippe, in any of the subsets, like bicuspids, for example, I think it was 9% of the cohort, did you see any crossover sooner, any higher mortality, waiting longer? Maybe just comment on bicuspids. We see a lot of that.
Not in this subset. Obviously, we're going to do deeper dive in clinical surveillance. What are the predictor? But this one didn't come up. But there's things that come up, such as peak velocity, for example, more than 5. PVD. Okay, people that are sick, more vulnerable. They don't have endothelial function to maintain the perfusion when they crash. So there's people that are more vulnerable, and that would potentially identify, say, hey, this one, you don't wait on this one. The AFib patient, you don't wait on this one. This one will have symptom after 3 days, you know? So, but we're going to see at ACC, and then we're going to have a deep dive on that. I'm almost done with early TAVR. So one thing in early TAVR was good, and the TAVR was amazing in both group. You see the early TAVR, 0% CV death. And when you cross over, in spite of being in deep water and 40%, 0% CV death. So that's the problem. Early TAVR is too good. If you're diminished and you wait a year and you have open heart surgery, you're going to die. Why? Because it's open heart. But TAVR, we know, is like a 30 minutes procedure. You go home the next day. You may stay longer if you have pulmonary edema, but it's very rare to have a death on the table or in the hospital. And that's
Philippe,
the problem.
30 minutes. That's a long time for you. I thought that's 2 cases for you, right?
Well, we have to stay humble, you know. But I'm trying hard to stay humble. But then when you look at stroke, for me, obviously, we didn't put the emphasis of this, but 0.9% stroke in early TAVR, 1.8 when you wait. Again, if Sentinel have those results, they will be thrilled. Okay. If you look at a new permanent pacemaker, 5.7 if you early, 8.4 if you late. All those little signal for me or information that say, why do you want to wait? There's nothing actually in this data set that show that waiting is good. There's nothing. I'm looking and I want to wait, but I can't, because there's nothing that show you that it's good to wait.
I think, Philippe, that's the most important part of this. You're one of the most important parts of your results is that we didn't harm anyone by going sooner, and you're not hurting anyone. And so, I mean, and that's the knock against all of the interventional trials, is that there's a risk with what we do, but you actually showed the risk is paradoxically lower, and which is great.
Yeah, I think for me, this table, unfortunately, is in the appendix of the New England.
Oh, really?
And yeah, because we only have, like you know, we have five-figure table, so we have to choose carefully. Obviously, we're going to write a lot of sub-analysis, but the appendix, I invite everyone to read the appendix. There's so much work there, and there's so much richness, and the trial is there. Okay, there's so much, it's so rich, the appendix. But so
for you to say it's safer for you to go now, it's huge for the patients. It's safe from the procedure as well as the long-term outcomes. It's huge.
Yeah. Not to mention, you take all the subjective discussion points about this out of that equation. You know, you have severe AS. We have evidence that, you know, would support treating this now as opposed to waiting. And it makes the discussion with the patient flow so much easier, you know.
And I think what I like about early TAVR is that for the first time, it give us some data point to talk with the patient. So for me, what I do now, and I had a couple of patients coming with no symptoms since TCT, I say, hey, get ready, get the CAT scan. Let's put our ducks in a row. Let's get organized. And I think what was good in early TAVR is we tested the clinical surveillance at its maximum, what the clinical surveillance in the guideline was intended to be, meaning you follow like a hawk the patient, and if they have a symptom, you treat. You don't wait. And unfortunately, the reality is, and especially in different geography of the world, access to care is not perfect. And if you wait to get the CAT scan, for example, if you have someone come in the valve center at Morristown, even if we're really fast, get the CAT scan, get your teeth out, get the surgeon, it's like 3 months. And you waste time, and then the patient come crash and burn with creatinine 1.7, you need to do CAT scan rush. And this is where the mortality creep go up. So we really test the clinical surveillance at its best. And we applied its best, and still we had unpredictability of crossover of 40% with advanced symptoms, pulmonary edema, cardiac damage, quality of life drop. So it's really it's kind of humbling for the clinical surveillance. And why do you want to wait? For me, if someone want to wait, I would say it's a class 2B. You can wait, but I have to inform you that there's a risk, and I have to inform you, don't go too far, don't push yourself too hard, and there's risk to wait. And for me, early intervention is become a class 1. It's a fully personal statement. And waiting become a class 2B with a caveat, you don't wait more than 3 months or 90 days if you have symptoms. Otherwise, you may pay the price of mortality.
Philippe, I have a couple questions for you.
Yeah.
So when we see a patient and we're consulting on the patient, a lot of times the patient will either say, you know, I don't want this done, or they'll say, I don't want to wait. And, you know, the argument previously, you know, and I've been following your data on cardiac damage, you know, and have been very fascinated for a long time, thinking that we may be monitoring the wrong things. But for that patient, we've always explained, well, there's the potential of not needing another procedure at the end of your life if we wait and we push it. And, you know, do you foresee that that you're going to follow these patients out and see if they have early valve failure, or if they're going to have better longevity of the valves because you've put them in earlier, possibly, and they're having less urgent TAVR? And then the second question, if you can speak to it, you're probably the expert on how we decide on a marker of severity, looking at your scale of cardiac damage. In 5 years, how are we going to decide who gets a TAVR?
Mm-hmm. Yeah, this is a big question. So I think for me, too many times we live in the future. And we say, 12 years, you're going to need a valve. Like, we forgot that this patient may die in 2 years. And we forgot actually the valve, like, we just don't know. So I think for me, the money is with moderate, okay? Because when you do the valve in moderate, the calcium score is 400, not 2000, okay? The valve is more expanded, the leaflet work better, and you're probably going to have durability benefit, in my opinion. More circular, et cetera, et cetera. I can't wait to see the stroke rate and expand to in progress, but I can tell you, if there's not a lot of calcium in the valve and then your arch is clean, the stroke rate may be like less than 0.9. Yeah. So I think the sweet spot is moderate. Obviously not 1.5, but, you know, 1, 1, 1, 2. Mean graph 26, 30, you know. The other thing is, yes, you're going to have survivor. You're going to have, we have patient at 4 years that didn't cross over. Their heart is so thick. It's ridiculous. I look at this heart, it's like, Jesus Christ. Like you see that the peak velocity is 5.5. The heart is thick. I'm fine, doc. And I have a patient like that. I changed the valve, okay, because it was short of breath, BNP like 9,000. 6 months later, cardiac arrest.
Yeah.
And then we resurrect him, okay, come back EF 25. Now he's terrified. And there's no trophy for the one who waited the longest, okay? Yeah. And I'm guarantee you, and if you go again in the appendix at 5 years, you start to have a cardiovascular, the cardiac mortality start to separate at 5 years. And I think at 10 years, the accumulation of the cardiac damage, more stroke, more LVH, more fibrosis probably, in my heart, I believe we're going to have benefit of mortality in CV cardiovascular mortality. Obviously, 85 years old, you're going to start to die from cancer, you're going to start to die from infection. So that's going to mitigate. But in younger patients, 70 years old, I think that would be very interesting because I think the accumulation of cardiac damage in DLA and DLV, the more stroke, you're going to see a separation. So too many times we live in the future, like, in 12 years and the patient is 76, like, guys, like, you know, then we focus on the first 10, on the first 5. Obviously, if you're 96 years old, and you're mentally, you're neurologically, mild dementia, you don't do much. Of course, it's like now is risk benefit and etc. In a 76 years old active person that push themselves, I would say there's no, like Paul said, and I'm going to go to the conclusion because this is the conclusion we said, is giving the benefit observed and the lack of harm. Early TAVR may be the preferred option to compare to clinical surveillance in patients with asymptomatic severe AS, especially when combined with the challenges of a timely symptom recognition and prompt treatment in a real-world setting. So the lack of harm and the benefit that we see, for me, close the deal. And in 2024, we don't need to see benefit of mortality anymore. If you see a benefit of mortality, it means that the equipoise was not there. It means that you did something wrong. And if we had a benefit of mortality, let's say 50% reduction in mortality, we will have been accused to have bad clinical surveillance. Oh, you didn't follow them close enough. Oh, follow them over 3 months. It become impractical. So for me, the fact that we didn't have a price to pay in stroke and mortality, and we have all those little wins, those signals that goes in the same direction, is very reassuring. We designed the trial with the assumption that we're going to lose 1% mortality, 0.5% mortality, and 0.5% stroke. Because I designed this thing like we have 1% or 1.5% stroke at 30 days. We didn't. So, so this is learning. This is why we do those trials. So I'm going to stop there because I think I took a long time, but so, you know, thanks to, obviously that was a compound effort. I was the cheerleaders of this, and the patient. I want to thank the patient, the site, and the early investigator that really poured their heart into this. And obviously it was published at the same time as the presentation in New England, and I think a big achievement for all of us and for the field. And I think it's just the beginning. For 20 years, we tried to prove that another way to do AVR was good, but now we just advanced the field. It's the first time. And it's just the beginning. We're entering the era of preventive valve disease, valve therapy, with progress, with evolve too, and more to come. So, yeah. So I'm going to stop there, but thanks for that.
Congratulations on a trial that's going to change practice. This is excellent. Thank you for your time in presenting this as well. This is really exciting.
It's a pleasure.
Yeah, thanks so much, Philippe. That was great. Paul, you want to pull up yours? And then, you know, I think one of the cool things about early TAVR is there's a few trials where the external validity has a magnitude of benefit bigger than the magnitude of, just like you said, Philippe. If you extrapolate your findings to a real world setting, you're going to save so many more patients than you did in the trial. You know, I mean, it's huge. You've really changed the paradigm of management of aortic stenosis.
Okay, can you all see my slides?
Yep.
Well, thanks very much. So I was asked to share this presentation that we did at Shark Tank on some new technology that helps manage patients with TEER. This is a company, and in full disclosure, I'm one of the founders of this company. It's called AMX Technologies. So I'm going to share with you some of these findings, which I think will be very interesting to see what happens as we go forward in our practice with mitral and tricuspid therapy. And so the premise of this is that we know that TEER is a dominant therapy for patients with MR and TR, and it's because we have this repair first mentality. And repair first is a standard care, and we know that hundreds of thousands of patients have been treated with TEER worldwide. Now, one of the issues with TEER, though, is that post-procedure regurgitation is quite common. We know that if you take patients and look at your experience across the world, that either persistent, that is an acute failure, or recurrent, despite an acute success, with severe regurgitation happens anywhere from 20 to 30% of patients. And thus, what we know is that there are many patients walking around with residual regurgitation, and by 2030, that over 40,000 of these patients will be walking around with significant findings like that. And I think a lot of us struggle with what happens to these patients and how to manage them, because they're very, very difficult. Patients who have post-procedure regurgitation have very poor prognosis. In fact, if we look at how it affects them in terms of survival, an acute procedural failure with TEER, with mitral TEER, it's a death sentence. 1-year mortality is actually 50%. And then worse is that surgery for these patients is just really a high risk proposition. Almost none of them get repaired. The mortality is over 10%, and it's much higher than what would be expected for the predicted risk.
And Paul, if I might interject here, Paul, I might interject for one second. What's so important about this, guys, is that when you have these patients that were deemed high risk or not a good operative candidate to begin with, and you clip them and get suboptimal results or recurrent MR within 6 months, now the surgeon absolutely doesn't want to touch the guy. Because like I said, he was high risk 6 months ago or a year ago. So I think it's so important that when you look at the phenotypes of these patients, it's really key we understand that they have the ability to do redo TEER or a different therapy from the word go.
Yeah, I mean, you're absolutely right, Tom. I mean, the indication is higher prohibitive risk, and somebody who is higher prohibitive risk before only gets worse in terms of risk when your success is not happening with TEER. So you know, to help mitigate or try to address these patients, off-label removal or laceration has been done in a number of cases. So the very first case in the world was actually done at our hospital, and you can see that it's actually on the left-hand side here. That's the first laceration with a clip. One of them was an SLDA, so we only had to cut one of the tissue bridges, and then we put in a 10-9. Over there on the right-hand side is an example of how this can be done with a removal device. This is called the LASTA plus ONO. And in these procedures, a wire is used to lacerate these tissue bridges, but one of the challenges is that not only are these technically challenging, but there's a really pretty significant risk of collateral damage. And that's because the wire that's used to cut these tissue bridges can be indiscriminate. And where one positions and pulls, you can actually cut a lot of the mitral valve. And so on the far right, this is a picture from Jamie's paper that showed his ability to remove this device, but I just asked you to look at how much of the valve is also removed with the clip. You know, it's a pretty large amount of the valve, which is really just not optimal when we're trying to help these patients and also optimize the results with valve replacement.
And Paul, just to reinforce that concept, and keep in mind then, when you, and I'm sure you're going to talk about this, I know your talk, but the ability to remove tissue leaves less tissue behind. And so you're going to need a device therapy acutely that is leaflet agnostic to mitigate the wide open MR you're going to have acutely.
Yeah, and it's actually pretty interesting that this picture on the right-hand side that Jamie was still able to do an M3 despite a lot of those cords and leaflets being removed. But overall, I think the general impression is that it's not ideal to have that much valve removed. And so this is a system that has been designed to purposely address these issues. So this is the AMX, transcatheter TEER management system. So on the top left, you have your 24 French steerable. It's transfemoral. And then the most important thing is that we actually have a variety of cutting tools. These cutting tools have electrodes that are positioned, insulated appropriately at various places, either at the top of the arc or at the tip. Like a lampoon, and they can be used to cut cords, leaflets, and importantly, they come with a variety of shapes, which allows the operator to work like a surgeon, just to cut various parts of the tissue very carefully. We have a snare and a retrieval basket, and I'll describe how that's helpful in the procedure, but most importantly is that the system is designed to remove any TEER device, any size, shape, or brand, and enable any TMVR or TTVR therapy, whether you need cords, leaflets, or not. And so the way this works is, if you start on the left-hand side here, this is how very much like a surgeon would. So, you know, we cut the amount of tissue that surrounds the device first. We're using cord cutters or very specific cutting tools. And then on the picture next to it, second from the left, we use that snare. And that snare, it works like a surgical pickup. And so if you think how a surgeon does this, you know, they pick it up and then they hold it such that it creates countertraction so that you can cut at the base of the device. And so that countertraction is what prevents the indiscriminate cutting. So on the image to the right, you can see there that the snare is holding the clip, and then the cutting tool comes over and cuts just at the base. And we've also created electrical algorithms that are specific and have been tested for their delivery, as well as reducing the risk of thrombosis, which is important because, you know, the Valley Lab generators that we use for cautery in the heart, whether it's lampoon, basilica, what have you, we actually cannot tell you how much energy is being delivered, how much the patient's received, nor can you actually know what the amount of risk of thrombosis is in terms of cutting within the blood pool. And that's the issue with that. And so we have partnered with EARLY generators, and we've created these special algorithms for this therapy. And so, and then the far right, the final step is we place a basket in the atrium, and then the device is placed in the basket for removal from the patient. So this year we had a couple of cases with the current generation. We're on the second generation of the device, both in Europe. Roy and Slavic did these cases, and you can see these were both patients that had chronically implanted Mitraclip XCWs. They were actually partially open, 30 to 40 degrees in each case. And you can see how much we preserve, how little tissue we take when the clip is removed. We focus on the images in the middle for both of those. It's just taking the clip, very little collateral damage. The image on the right-hand side, you can see an ancillary cord coming out the front of the clip, which is very common. And again, just minimizing the amount of tissue damage. In both these cases, had tendines and did great afterwards. This is actually a video from Slavic's case, and he created this on his own because of his enthusiasm for the device, and you can just see it in action there. There's the basket and its placement in the body, and in the basket and the removal from the patient. Lots of smiling faces there.
Wow.
So, you want to see it again? You can see it again if you want. Yeah. So here, this is.
That's amazing, Paul. That's amazing.
Yeah. Yeah. So
I need to hire him for my marketing crew here in TMC. The guy does great videos, huh?
Well, the remarkable thing is the timing too. I mean, this took 30 minutes skin to skin for him, and the other one was 1.25 hours. I mean, it's really remarkable.
And it's mainly fluoro guided, Paul?
Yeah, so it's mostly fluoro guided. We obviously have echo there because we want to have echo there.
Sure.
But you can see everything on fluoro if you just look at like how where this is positioned. If you're in the right ML trajectory, you just have to steer down to the clip, and everything's radio opaque, and then and beyond that. And
makes sense.
Paul, this is the echo guy asking if it's fluoro based.
Oh, is that right? Okay, yeah. I'm sorry, I couldn't see.
Are you making me jobless?
My screen share does not let me see who's asking the question. So sorry.
Right.
But the other thing too is that the device. It's a single plane steering too. So if you think about that, you just have to steer in one plane to get there. So we have a really exciting clinical regulatory pathway that is anticipated to start really soon. We have compassionate use cases we'll be doing into Q1, and then hopefully EFS through next year, and a pivotal study to start after that. And right now, based on our discussions, we're anticipating 75 patients or so with 30-day follow-up for both mitral and tricuspid, and approval sometime at the end of 2027. So very, very exciting. We have excellent coverage from a patent portfolio. We have freedom to operate, lots of claims, and we have priority based on our filings too. But this is what I think is most exciting about this, is that when we look at the value, if you're a TEER fan, and you all know that I am, and I believe many of you are too, right now we're so focused on this green. Of course, a lot of us do reds, and a lot of us do yellows, but it's not without hesitation, right? And so what AMX does, it gives us comfort to move out of those green zones, because if we can push the boundaries a little bit, if we need to, we can do it more easily if we know that there's a backup option. And so the value proposition here is obvious, because we would increase the number of cases based on our market research. And you guys tell me, our physicians have said 15 to 20% more cases if we have a backup option, because there's just more comfort. So, and then if you're a fan of TMVR, TTVR, it's the other side. So the current main market is your TEER unsuitables. All the trials right now are, you have to be technically unsuitable for TEER. Well, that's just the red. So what about all these other patients that are getting treated in green and some yellow? Well, the nice thing about AMX is it pushes you out there, because it turns out that the prevalence of TEER failures is really large, and it's actually more common than severe MAC. So just think about that for a moment. And I'm the MAC PI for 10-9, and we have MAC arms in all of the clinical trials, but MAC is less common. Severe MAC, that is, with mitral disease, is less common than TEER failures. So it's to me, it's pretty obvious. And this was one of the main arguments that we were making at the Shark team. The other argument is that, yeah.
If I might interject again, in my humble opinion, I think that with the right device, and maybe 5-10 years from now for TMVR, maybe not such for TTVR, but for mitrals, I think replacement will be the predominant therapy for interventional use when we have the right device. And I think this really, for me, reinforces that. These TEER unsuitable or yellow cases, the red and yellow, I think will all be TMVRs in the future, and the green will continue to shrink for mitral TEER. FMR may be different, low EF patients may be different, but I'd say the majority, 2/3 of mitral interventions transcatheter will be replacement.
I think you're right, Tom. I think that things will shift towards TMVR when we're able to have the right technology. I hope that's the case. We've been waiting 10 years. So, and I think we're fine.
And it very well may be another 10 years, honestly, Paul, but I can tell you for reinterventions alone, and, everybody's facile with doing valve and valves pretty regularly, right? So the issue with TEER is, and we're starting a trial called Save Mitral because of this reason. When you have a limited EOA and you have moderate or greater residual MR, that's always the struggle, right? Do I put another clip in? Do I do a Pascal with the spacer? How do I approach this? Do I try to lacerate a leaflet and put an Alta valve in or a Tendyne? So I think we're beginning to understand more and more in the mitral space, reinterventions will be easier with replacement as a foundational gatekeeper for future interventions.
Yeah, I think so. And, for tricuspids, I think there's a little bit more discussion too, because, like right now, the safety profile with Mitraclip is so much more superior than with Evoke.
Agree.
And so right now, for tricuspid, it's, in my opinion, repair first until. And so, but we have lots of replacement technologies. My role in that too. So I'm a fan of all three of these. And the nice thing is that AMX hopefully gives people more options between the three. So, but this is part of the Shark Tank presentation. But if we look at the pull through, it's a pretty large market. It's $1 to $2 billion for the financial opportunity. If we look at pull through for TEER as well as valve implantation, and even if you just focus on TEER management alone, and that business in itself is $375, and that's assuming an ASP of 10,000, whereas Parcardia is more than that, and so it's actually quite a bit more, and it's actually twice if you include OUS, because OUS is always about 1.5 times that of US, so pretty large amount. And this is my final slide here, is that I think what we're trying to do is we're trying to do this because it's about the patients. And, so Tim was actually the first one to use AMX and successfully and do an Intrepid. And that's his patient, Paul, there, who is very grateful. And we've engaged a lot of people. And Tom, you gave me your permission to put you on the slide here. So thank you. The enthusiasts are really large for people who believe in lifetime management. And I hope our company gets the final round of funding here soon, and that we're able to do more of these cases, because these patients are everywhere. They have acute and chronic problems that really need management. So with that, I'll stop, and happy to take any questions from you. And thank you for this opportunity.
Paul, wow. That was fantastic. What French size is the system? I may have missed the beginning of it.
It's a 24.
24. Gotcha. Same size MitralGuard. Perfect. Mark, when you see this, what do you think? You think you have some patients in the mitral pipeline that are waiting for a redo TEER that are 85 and maybe need something else like a replacement?
So I think if you're a TEER implanter, you have patients in your pipeline, because ultimately, especially with degenerative MR, you're going to have progression of the disease. I mean, we have a limited understanding of the long-term outcomes of this. We're going to have to treat these people over their lives. It's interesting, because I think that and I think for the broader audience, it's important to understand how essential this is. So I'm going to ask a stupid question, because stupid questions are quite beneficial. Why not just crush the clip over to the side of a TMVR?
Great.
We've all seen Evoke with the T-tier clips crushed over to the side. So why not just do that?
It's a great question, Mark, and I'm glad you asked that. And so that's how we did Elasta in the beginning. One of the, there are at least 4 reasons why not. First, Elasta, or the crushing technique, it doesn't work for all patients. So in other words, like if you have an anterior SLDA, or you have a bridge that you cannot cut anteriorly, you have to cut posteriorly, then the device might end up in the LVOT. And then there's a greater risk of embolization. So there's some anatomy that doesn't work. Let's say that there are devices in the commissures, or you have multiple devices with very large tissue bridges that go across 2 or 3 clips that are in place. Very hard to cut. Another reason is that these devices, there have been instances where the follow-on therapy has not been able to be fully expanded because of the tissue bridge left in place. And there have been instances with actually malposition of devices. I don't want to call anybody out here, but there's been malposition of devices. There's been PVL. And I had a patient with VT because of the clips hitting the sides. And there have actually, and I can say this, in TriClip patients, for the SLDAs that happen, those SLDAs have been associated with VT as well on the RV side. So you're absolutely right. We could jail them, but in all honesty, it's better to take them out. And that laceration and jailing, the risk is collateral damage because you're cutting so much more than you need to. So
I think, Paul, I have to congratulate you. This is unbelievable because I think you're right. I think what's going to happen is we're going to push there, and that's going to give us the freedom to push the limit, and then if it doesn't work, you remove it, but you have your TMVR in backup. Mm-hmm. So I think the procedure will be like that, and I'm sure you know what TMVR I'm thinking as a backup. But if you remove the clip and you have,
yes,
a valve to put on top quickly, I think that's pretty awesome.
And hopefully you've led the way with Precardia. These Picardia, these are all like surgical-like tools that allow us to modify the leaflets in a way that a surgeon does in the OR. And that's where that lifetime management becomes so important. We need to be able to do everything from the groin.
Yeah. So there's definitely, and I like it's very elegant. You don't remove the entire valve, and I don't like to gel clip and stuff. I mean, the heart is not a junkyard, where you push things on the side. It's like sometimes I'm like, you kind of jail leads and you abandon leads. It's like, again, my body isn't a junkyard. We don't jam, we remove, we start fresh, and we put a valve on top. So I think brilliant. Congratulations. And you could put my picture as an enthusiast too also.
Yes, thank you. If I could add all your pictures, I want to add them all. So thank you.
Yeah, keep growing the photo up there. Paul, let me ask you, and then I'm going to pivot to Joe Walsh if he's still on. Is it easier to remove a tricuspid or a mitral clip?
That's
from a procedural standpoint. It seems that maybe TriClip might be easier, but what's your bailout for TriClip acutely?
Yeah, so it's a great question. So we have not done a tricuspid yet, but I gotta believe that tricuspid is easier because, the mitral there's this fear of hemodynamic instability. It actually hasn't been that common with Elasta. A few instances here and there, but it actually is because when patients have severe MR, you're not really increasing the burden that much when you're doing Elasta or these therapies. And but most people, I think, would feel that for mitral, the follow-on therapy right away is important. Tricuspid, I think it's actually, first of all, the residual regurgitation is higher with tricuspid. And then second of all, I do believe patients tolerate the TR more. So it's a matter of the devices. Evoke has been used in Elasta, where they, as you guys mentioned, jailing the clips on the side. That's been done already. But I think we should be in the business of removing. So.
Interesting. I think Philippe makes a great point about an atrial fixation type TMVR system. Makes a lot of sense in that scenario that's leaflet agnostic or leaflet independent. for the tricuspid, would it be something like a cable stented system, like a trick valve, for example? You just remove more leaflets and simply make it a conduit. I think that may be something for tricuspids potentially if you can't get enough leaflets to grab.
Yeah, another option would be V9, because V9 doesn't require leaflets, or Topaz. Topaz is a pretty good frame. I think
Laplace, actually, Laplace, I guess, could do. Yeah.
I actually think Intrepid could work too. And Tim did an Intrepid for the mitral. I'm pretty confident it'd work on the tricuspid too.
I got first in Shark Tank, man.
I lost by 1 vote. Can you believe that?
Oh man, I don't
get it. Apparently, I talked to Juan Granada, and he said, "Don't worry, Paul, I voted for you." So it's okay, Juan.
Joe, that's what I was going to ask you. I was like, look at this technology that Paul's working with, and it's amazing that we have these concepts that can come to fruition that are a really unmet clinical need. You mentioned picardia for leaflet splitting with Philippe. I mean, that's just phenomenal. Those tools, there's so many in structural heart that we need. I think these two are very nice examples of how it's going to make our patients better with better results with new technology. Joe, when you see this, you think about the future. What do you think about in programs that maybe not have the ability to have a TMVR as a backup? How do you think they'll approach these maybe smaller, medium-sized centers?
So for centers that do not have TMVR as a backup?
Correct.
Well, you have to have an exit strategy if you're going to be removing a clip. So, I think you'd have to have TMVR as a backup would be my thought. I guess you could reclip if the first clip was malpositioned or if there was a problem with the first clip. I think this would be an excellent strategy to reclip the patient, especially if technology continues to improve and you've got better technology to do TEER. But I think this is just leveling the playing field for us compared with surgeons. And and no one likes to talk about this, but it's really hard to do some of these electrocautery procedures without dedicated equipment, and that's where Philippe's device, picardia, and this, I think, really are gonna help translate this to broader centers, not just the elite couple centers that are doing 10 electrocautery cases a week.
Exactly. What I was alluding to is I wonder if you're going to do a bailout TEER after you remove the initial TEER, would Pascal be a better device with the middle spacer if you have leaflet tissue that's going to have a gap already? So I was curious to think it may potentially, if you do not have a backup TMVR, would something like a middle spacer type device like a Pascal or Pascalise potentially be helpful?
So Tom, I think that's an interesting question, but I would really be hesitant to not transfer somebody to a TMVR center because you're going to have to be able to anticipate exactly how much leaflet damage happens, and I don't know that that's predictable. And I think that Paul's device makes it a whole lot more predictable than just ripping the clip out. But I think that you need more exit strategy than a Pascal.
Yeah. Excellent. Any questions or comments from the audience, Zach or Joe?
I don't think so.
Mark, thing I would just say though, if you have an acute SLDA, this would be ideal for it.
Yeah.
Because right now we with these SLDAs, we put one on each side and we kind of hope for the best with regurgitation in the middle. Just think, if you have an acute SLDA, you could take it off and you could potentially put another clip on right away. So,
that's great.
That's a very great point, Paul. That's a very wonderful comment.
Yeah. Thank you, guys.
Great. Well, guys, thank you so much. This was a great overview. Philippe, thank you for your time. Thanks for your contribution to the space. And Paul, really amazing device. Thank you for innovating in this space. It's much needed. So thank you so much. We'll send this out to everybody. We'll get this on all the socials, YouTube, X, MurmurMD. So thank you guys for your time. We really appreciate it.
Awesome, guys. Mark, Joe, Zach, Philippe, Paul, guys, appreciate your time. SWAC on MurmurMD, guys, appreciate it. Have a great night.
Thanks so much for the opportunity.
Bye-bye.
Take care. Bye-bye.
Guys.